This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of pre-hospital care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast, even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, this is going to be the first of a three-part episode into mental health within pre-hospital care. And the first episode really is going to be looking at the structural approach to how you embed mental health services within pre-hospital care. And so we're going to look at London Ambulance Service, and we're really going to do a deep dive into how mental health services are embedded within London Ambulance Service, one of the busiest ambulance services in the world. So it's true to say that mental health crisis are one of the most complex and indeed sensitive challenges faced in pre-hospital care. So London Ambulance Service plays a critical role really in responding to these emergencies from the moment a 999 call is made to the frontline crews delivering urgent intervention on scene. But some of the questions and the prescient aspects we'd like to look at is really how the system works as a whole, and also how these calls are assessed in the control room, and also what do some of the specialist paramedics and mental health professionals play in shaping patient outcome. So in this episode, we're really going to do a deep dive into pre-hospital mental health response and explore how London Ambulance Service, or the LAS, manages real-time mental health incidents, the operational and indeed the clinical decision-making that happens behind the scenes, and the challenges of coordinating care across multiple agencies, really. So joining us are colleagues from the London Ambulance Service mental health team who really will share their experiences from both the frontline and the emergency operations centre to give us a full picture of how pre-hospital mental health care is delivered and indeed evolved in one of the busiest ambulance services in the world. So Carly Lynch and indeed Dan Phillips are joining us. Welcome both to the podcast.
Hello, thanks for having us.
Thanks, everyone.
I wondered if we could just kick off, really. And indeed, Carly, I'll come to you first. Could you maybe just give us an overview of how the LAS responds to mental health crisis in real time?
Yeah, so the initial phase of the response will be the call kind of coming into our control room. It could be that it's the patient making the call. It could be it's a relative, a member of the public, a healthcare professional such as a mental health team or GP that's seen the patient. And then it can also come in via the police through our electronic system, where our kind of computer systems talk to each other. So there's kind of multiple entry points where the 999 call may come in. So the call is triaged using our kind of triage package that we use. And then once the call is complete, a response will be kind of assigned to that particular call. It could be that the patient has a telephone assessment within our clinical hub. We do have, as well as paramedics, mental health nurses embedded. So our mental health colleagues will be kind of calling people back to see if they're on the most appropriate kind of pathway. Do they need the ambulance? Does the call category need to be upgraded? Or could they be seen maybe by a mental health crisis team? So if a face-to-face call is needed, an ambulance will be dispatched. So it could be a kind of regular ambulance, what we call a double crewed ambulance, or it could be one of our kind of specialist resources, mental health joint response car. And we also have some mental health transport ambulances that convey our patients who've been detained under Section 136. And for people, international listeners to your podcast, that's where patients have been detained by police under a section of the Mental Health Act, and then they're taken to an appropriate destination, which is usually a mental health hospital. So once the kind of ambulance arrives on scene, whether it's the mental health joint response car or a regular double crewed ambulance, they'll complete an assessment of the patient, find out any collateral information. They'll ring the local crisis lines to see if the patient is kind of known, any kind of risk assessment or kind of background information that may be useful. If needed, the double crewed ambulance can call through to our control room, to our clinical support desk, where they can speak to senior paramedic or mental health nurse who can kind of help with their decision making. And as well as the kind of mental health assessment, they'll also have a physical health assessment, because we can't separate the two. Mental health and physical health kind of go hand in hand. And we know that a lot of our patients who have mental health problems and will also have physical health problems, and then they may not have kind of seen their GP or accessed any healthcare. So the aim really is to kind of de-escalate the crisis, and see what needs to happen. Obviously, there will be absolutely times where the patient does need to go into the emergency department, but the aim of the mental health joint response cars is definitely to try to avoid conveyance where possible, and if it's safe to do so. And also we're working hard with our double crewed ambulance colleagues to access kind of care pathways in the community again, if it's safe to do so.
And listen, that's fantastic. And like you said, there's that kind of bilateral assessment of their physical and mental health. Dan, could I bring you in and just get you to speak to really how you have embedded, because true to say, the service has evolved over the past few years, and you do have mental health professionals working side by side with specialist paramedics
Yeah.
to deliver this service. Could I get you to speak to just how you've embedded that team and how that team works almost symbiotically?
Yeah, absolutely. So the mental health professionals and paramedics um, have been obviously working together now so very closely. I think mental health professionals were first introduced into the trust back in 2015 in the control room. And then really excitingly from 2018, we launched our pilot mental health program, which was just mental health car program, sorry, which was just one car in Southeast London, which has subsequently expanded across the city. Just to quickly summarize the car and the way it works, we have a paramedic and a mental health nurse who work together responding to mental health crisis calls predominantly, but obviously being an ambulance, we're also category 1 available. I was lucky enough that back in 2018, I was able to be one of those first paramedics on that pilot program. And I think at university and bits and during education, we talk very heavily about the benefits of interprofessional collaboration. But I do think paramedics often don't actually get to see firsthand the real benefits of sort of working so closely with other professionals beyond sort of making a referral over the phone or handing over an ED, the emergency department. So from day one, I was working alongside mental health nurses, occupational therapists, and the social workers who we have on the team. And it sort of immediately was just sort of very clear how that collaborative approach and bringing the skill sets of all these professionals together really enhances the patient experience and what we're able to deliver. I know, for example, that my practice has certainly improved significantly as a result of that time initially on the secondment. I remember actually when the secondment ended and I was sort of back working on a standard double crewed ambulance, just after attending sort of relatively sort of complex mental health incidents. Obviously wasn't performing to the same standard as a mental health professional, but I remember my crewmate at the time, being quite surprised at the sort of how my tolerance of risk with this sort of cohorts of patients has changed, and the threshold I now had for assessing, de-escalating, and sort of sharing risk with mental health providers. And actually, what's been so interesting, sort of coming back onto the team as the mental health paramedic lead and assisting Carly with leading the team, has been actually a sort of a really nice little anecdote. We actually had that sort of same crewmate who back then was sort of quite surprised to see the way that my practice had changed. Actually came and joined us on the team for a secondment because they wanted to sort of gain that same experience. In terms of the two roles working together. You know, I think as I've sort of mentioned from day one, it's the two professions just seem to gel extremely well. And I think Carly would agree with that. We obviously cover two different aspects of the assessment, which seems to work quite seamlessly. So the paramedic being responsible for the physical health screening, ruling out, you know, physical health red flags, knowledge of local pathways, should there be an underlying issue that we pick up on and need to address there, and also the operational knowledge of the pre-hospital setting, while the mental health professional brings, you know, advanced mental health assessment, you know, enhanced de-escalation skills, and then I guess the big game changer really is their, you know, far superior understanding and of risk and ability to sort of weigh up that risk that that comes from, you know, all their years of experience in mental health settings and with these patients, and the greater understanding of sort of what mental health pathways are available and what they can offer. So yeah, I guess just to summarize, it goes back to sort of what Carly was saying. And, you know, we'll probably sound like a broken record on this by the end, but, you know, we can't separate the mind and body. And so I think the beauty of this model and the two professionals working so closely together as we assess the person as a whole, you know, we have a very holistic approach. And, you know, obviously, I think what's so great is we've now had a lot of paramedics who have come through the team and who are sort of applying to come through the team. So, you know, our team and the car does amazing work, and, you know, we have a very safe service, and we save the NHS a lot of money. But actually, even more importantly, I guess, all these paramedics coming through, you know, will be significantly enhancing their care and expertise. And when they finish with us, they'll be taking that back into their practice in whatever setting they're based in.
Which is fantastic, absolutely fantastic. And a question on the back of that, Carly, I'll come to you, really is around, because I think a real adage of the service is the fact when the mental health car and or resource isn't available, you still have reach back services within the control room to be able to consult. And actually the beauty of it is there is so much, you know, mental health work really that London has to deal with, London Ambulance has to deal with, and actually having that reach back for the wider double crewed ambulance, which doesn't necessarily have the ability to have a resource on scene.
Yeah, so I think just for some context, mental health is around 10% of our daily demand in terms of our call volume. And that's probably a conservative estimate, but it's kind of what our data kind of shows when our crews have coded their paperwork. So yeah, it's a huge kind of chunk of our work every day. And I think a reflection from me when I came into the ambulance service, which was also kind of 10 years ago, was that mental health services are very good at kind of sharing risk with one another. A lot of the kind of approach is a team approach. So if you're working with kind of complex patients or risk is escalating, there's never usually kind of a unilateral decision. And even if we look at more formal assessments, such as assessment under the Mental Health Act, there's, you know, usually at least 3 separate professionals that will kind of assess that patient and make a decision. So I think something that kind of opened my eyes to the ambulance service was, you know, that we have these kind of double crewed ambulances doing amazing work every day, and then obviously they're having to make quite on the spot decisions. They may not kind of know the patient, usually never met the patient before. Back then we were still, you know, on paper and things weren't as digital as they are now. So yeah, so it was really important for us that we gave our crews kind of access to that expertise actually, and even just kind of talking things through with somebody to help kind of reassure you that yes, this does seem like the best decision for this patient. Even if it seems quite obvious, I think sometimes that can help our crews to make decisions, and then the next time they're in a similar situation, they'll feel more confident at kind of taking that decision. And then obviously we may find ourselves on the more kind of complex end of the spectrum where we're kind of maybe concerned about somebody's mental capacity to make a specific decision. And I think it's really important that we we consult people, where possible, and that is also kind of good practice as well. So the crews may be speaking to the patient, what their views are, the patient's kind of relatives or next of kin or lasting power of attorney, but then also kind of speaking to other people, and having that kind of separation where you're not on scene with the person can also help with clarity, because a lot of our communication is maybe non-verbal, unconscious. We're like sponges as humans, so we may be on a scene with very what we would call high expressed emotions. There's maybe a lot of distress and anxiety, so it's really good to have somebody who is physically separated to have that space to talk things through as well. So I think it's really vital, and our crews, we've had like really good feedback about being able to have that advice. And sometimes it could be that the advice is, let's call the mental health trust to get some more information because they will have access to the records. But yeah, the team, I think our team, one of the best things when they're working in the control room is speaking to crews. Obviously, they enjoy speaking to patients, but you can really help kind of educate people, and informally as well. So yeah, it's a really valuable resource. Yeah.
Dan, if I could just get you to speak to really how you deal with some of the control room assessment and triage of mental health related calls before formative hospital care is in attendance to that call. Could I get you to speak to maybe the online or indeed phone-based triage that might be applicable to the more low acuity mental health calls, and how you sort of safety net and approach that aspect before there is, or indeed to mitigate any on-scene need of a formative response?
Yeah, absolutely. So obviously, I think the first thing that's worth saying about sort of mental health assessment in terms of triaging and assessing over the phone is it's really difficult. So much of a mental health assessment relies on observational information that again, this is something that the mental health practitioners are well attuned to pick up. Non-verbal cues, the surroundings, social factors, bits that just simply get lost over the phone. So yes, that's certainly a significant challenge in the process, and it's why more calls aren't dealt with as sort of hear and treat or closed down over the phone prior to a dispatch. Just the complexities around it. As sort of was briefly mentioned earlier by Carly, when a call comes in, there'll be an initial triage using the MTS triage system, where a 999 call taker will triage the initial call as it comes into the service. It will then be essentially placed into a stack of calls, which are based on the category the code is the call is triaged at. So like if it's a category 1, for the most life-threatening emergencies, category 2, if it requires like an 18-minute response, category 3, if it needs an hour and a half response, and so on. We then in the control room, sort of within the clinical hub and the clinical support desk, have, as Carly mentioned, a mix of both paramedics and mental health nurses, and other mental health professionals, who will be going through those calls prior to a dispatch, particularly obviously for the lower acuity calls. So obviously a dispatch to a category 1 wouldn't be delayed, but yeah, they'll be reviewing those calls, and then sort of targeting ones that are potentially suitable for a callback. So for example, when one of our mental health professionals phones that patient back, the way it will generally work is they'll run through again an initial sort of triage of physical health, just to again rule out any immediate deterioration or red flags that might require like a more immediate ambulance dispatch. And actually, what we find with the mental health professionals is once they've sort of cleared off that sort of very structured part of a physical health assessment and an immediate risk, they'll then switch into something probably a little bit more organic that they're in a kind of assessment they're more used to, which will involve both gathering information from the patient or third-party caller firsthand, accessing care records, and also sort of directly speaking to care, like mental health services on the phone. Similar to on scene, to try and try and form a safe plan that doesn't involve sort of an ambulance sort of reaching scene. I think it's important to say, obviously, an ambulance being dispatched, obviously, we'd never see as a failure. It's just simply about finding the right thing for every patient. And if we cannot safely contain that risk without attending scene, then we will attend scene.
So, Carly, could you speak to really the interplay between multidisciplinary team working on scenes such as the police and reaching back into maybe a mental health care team which is remote, and just resourcing that MDT approach, that multidisciplinary team approach, both on scene and remotely, either on a tablet or indeed from a service, just to really get the most information and indeed the formulate that plan, the best plan really for a scene response?
Yeah, I think it's a really good question, and I think the key to this being successful is actually around the communication and how that happens on scene, and also, as you say, kind of remotely as well. And it's making sure that everybody on scene, especially the patient, feels part of the decision making, because the police are kind of approaching things from one angle. I might be approaching things from a different angle. Dan, if I was working on a shift with Dan, and then the mental health trust, they would also have their own kind of, approach and needs and questions that they may need to answer. And sometimes when we kind of review incidents, it's always so apparent, isn't it, Dan, around the lack of communication. So, for example, a crew may be doing something with the right intent, and it's the right thing to do, but then the handover to the police colleagues on scene might not be so clear. So yeah, something that we're kind of looking at, and a big focus on our training is around the kind of communication and joining up the situation on the scene. And we have quite a good example where this is working well. For patients who the police are considering to place on the Section 136, what I mentioned earlier, in order to do that where possible, and it's not time critical, that police should be consulting a healthcare professional just to check in with that decision. And then regionally, in terms of kind of governance, the NHS England had set up some advice lines with the Mental Health Trust to get that advice. And then it became clear that actually LAS crews, if we're on scene, we're not always part of that conversation. So we could be handing over things around, the physical examination of the patient. We may have a slightly higher risk threshold, or our risk tolerance or view might be different to the police. So we've now moved to having a kind of a triangle approach. So everybody on scene is talking to the mental health trust nurse around whether that 136 should go ahead. So I think that's a really good step, because it's kind of looking at the person in the whole as well, and making sure that we're considering their physical health, and then also looking at it from the pre-hospital setting as well as the police setting, and then the mental health setting, because sometimes opinions do differ. And I think one of the things that I personally quite like about working in mental health is that, like, we do have a lot of difference of opinion, about maybe what's happening for the patient, what needs to happen. And that's where, like, having these professionally kind of curious conversations, actually that's where you kind of evolve as a clinician, because it helps you really see like different points of view that you might not have considered, and it kind of challenges you, and it helps with the kind of safety of the decision, because you can get very blinkered, can't you? As I said, on scene there's a lot going on, so like having other people to sound things off, you'll be like, oh, I hadn't thought about it like that. So yeah, I think it's really important.
So Dan, could I get you to speak to really some of the lessons learned from handing these patients over? Because you said before, and absolutely to the case, your mental health training and approach has evolved, exponentially over time, having been involved in this project. Could I speak to what you've learned in really handing these complex patients over to mental health teams in hospital. Is there any different, in a way, checklists or indeed handover protocols, or just speaking that same language to the mental health teams in handover of the patient? Could I get you to speak to how your practice has changed in handing these patients over to an MDT in hospital?
So in terms of the handover, obviously the LAS has recently, worked on various different strategies to improve, the handover process in general within emergency departments, which have been quite effective. In terms of mental health specific bits, I think the sort of Code 10 policy was introduced. I think Carly, was it the Royal College of Psychiatrists that sort of came out with the recommendation, whereby sort of patients that are coming in and maybe a bit sort of more complex cases requiring a bit more sort of immediate response upon arrival, but not necessarily a blue call patient. A crew could call ahead, or upon arrival, Code 10 could be initiated, whereby, and that will sort of trigger, or should trigger, a bit more of a multi-professional response upon arrival to the emergency department. So yeah, ensuring that the mental health team embedded in the emergency department are present, security if necessary, and an appropriately trained sort of like nurse or doctor to again take over the physical health need if as appropriate. So crews have the ability to sort of phone ahead initially and sort of make sure there's the required response or upon arrival, and that a big part of that is also about preserving the patient's dignity and respect for the patient, and not having somebody in an acute crisis, in a busy handover queue, which can be a really distressing experience for them. As well as that, the sort of, again, sort of on arrival and prior to arrival, actually, through our EPCR records, the hospital will have access to sort of the information immediately, to support the handover, and to also give a bit of an indication on route as to what's coming in, to allow for them to prepare. And I think one of the big things that I've seen that sort of that I think is really game changing, particularly for, obviously we can't be doing this for every single patient, but particularly for those really complex ones, or where there's really additional concern. Something that we'll do quite often on the mental health team is we'll ensure that, as well as sort of like the initial handover on arrival, if the psychiatric liaison team in the emergency department is sort of free and available, we'll try and sort of hand over concerns to them as well, just to sort of make sure that we've covered all bases, and to ensure that actually our risk concern it doesn't get lost in translation or lost on a computer system, and that we're sort of really making sure that they're aware of what's come in, and there's sort of no delays there. And that's sort of, as I said, it would be impractical and unrealistic to do that for every mental health patient. So definitely not saying every mental health patient that an ambulance crew takes in, we should be just sort of going and bothering the PLNs. But for those patients where, the risk is, I guess particularly the risk of them absconding hospital, and like there's a real concern around what might happen if the patient were to leave. I think clinicians will often, even if as non-mental health professionals, even if we don't fully grasp the sort of the risk and everything that's going on, on a theory point of view regarding the psychiatric side of it, I think you often get a gut feeling of something isn't right, and we need to safety net this patient. So having that additional conversation can sometimes be really beneficial as well.
So just as we come into land on the conversation, just a couple more questions. One really would be, Carly, to yourself, really around if there's any innovative pilot programs in place really at the moment to continually improve pre-hospital mental health care. Is there any other sort of alternative care pathways which are opening up, or indeed innovations you're working on in the space, just to improve that sort of seamless movement between hospital and pre-hospital?
Yeah, so I think the thing we're probably the proudest of, is that, well, next month now we're launching our pilot in advanced practice in mental health. So we are taking 3 paramedics and they will complete their kind of masters in advanced practice in mental health. And we've had a big collaboration with one of the unis. I don't know if we're allowed to give them a big shout out, but they've been amazing at kind of helping design the program because it was a first for them. So we're really excited to, we're starting, maybe it's my my anxiety and I like to start things small to kind of see how this is and how it develops, and then we can kind of take it from there. But I think that this is the sort of clinician that I see has having a great future in the NHS. The first three people we are taking are paramedics. And I think obviously you paramedics have amazing kind of knowledge in pre-hospital care. You're used to seeing patients, in pubs, in nightclubs, in their, and that's quite different for kind of a lot of clinicians working in the NHS, and your physical health knowledge. But then we're kind of bolstering their mental health knowledge at an advanced level. And as we say, we can't separate the mind and body. So I'm really excited to see how this looks in 3 years' time. So yeah, that's really exciting. So that's something obviously that we're doing internally, appreciating it is quite small to begin with. And then in terms of the kind of further developments, there's kind of early stage developments around kind of how remote advice and how that might look, partnering with kind of mental health trusts. So there's some early discussions going on to see that the scope in that, and kind of working together more closely. You may also have seen in the kind of UK government's plans for the NHS, they want care kind of closer to home, and there'll be some investment in they're called mental health clinical assessment services. So I guess it's almost like a mental health emergency department. So we already have some of those in the city. We've had them for quite a while, and they work really well for patients who, don't need to go to ED for any physical health concern, and they can go straight into a kind of more calming space, dedicated space, and resource for their kind of need, which is mental health. So yeah, we're looking forward to seeing more of those kind of pop up across the city, and then also obviously looking at, supporting our partners in prevention as well, because our call demand has been rising. Last year it went up 40%. So yeah, we're looking forward to seeing some kind of further prevention work happening. So it's never a good day if anyone has to call an ambulance. So hopefully kind of preventing things getting to the crisis point will only benefit our patients as well.
Just a couple more questions. One down to yourself really would be around if you could just share a case study, either low acuity or indeed high acuity, really of how the London Ambulance Service mental health response has led to a positive outcome, really. How, because I think the real one of the genesis of really wanting to talk to you about this is to really almost see how we can embed these services as a standard of care across ambulance services. So how this could be a forerunner as a standard of care both in the UK and in Europe. But could I get you just to speak to a positive outcome from mental health services being embedded within the London Ambulance Service?
Yeah, be happy to. I'm actually following on from, I think, a conversation that Carly and I were having a couple of days ago. I think there's a case Carly might have. I don't want to drop you in it at the moment, but I think there's a case Carly might have that would be good for this one. I don't know if you can think of the one I'm talking about, Carly.
Yeah, and then I think I can talk about the call potentially, and then bring Dan in if that's okay, because
Yeah,
the
perfect.
work. Yeah, so I guess yeah,
Yeah, let's do that. Yeah.
when we were thinking about that, I think and it's a really good point that you make around embedding mental health services, and absolutely the day-to-day kind of clinical response is what the team are here for, and we absolutely need to be responding to these calls and supporting patients in the best way possible. But I think when I was thinking about this kind of question, something that came up for me, and obviously in my role, is around the value of actually having leadership and a top down voice actually, and being able to make some change. Generally you can do things quite quickly in some cases. So having that kind of clinical response, but then a kind of clinical leadership response, I think you need a whole kind of team for this to work successfully. And I obviously, in my role, maintain my clinical practice and do shifts regularly on the mental health joint response car. And there was a case that I went to, and actually, it wasn't a mental health call. It didn't come down as that. It came down as a kind of category 1 call. It was kind of cardiac arrest, confirmed cardiac arrest. So we were one of the nearest resources. So myself and my colleague kind of got dispatched, and without going into too many details, it ended in a kind of very sad outcome that a young man kind of lost his life after what appeared to be him kind of engaging in kind of recreational drugs and something called chemsex, which you kind of may or may not have heard of. But for people that haven't heard, it's basically the use of drugs to specific drugs to enhance the sexual experience. And we know that it's generally with men having sex with men. And for me, obviously, that's a difficult call to attend for all clinicians. And it was just kind of very sad that this kind of person's life had been lost, and the circumstances into how it had happened, and people on scene didn't know the person's name, and he'd gone to this kind of hookup. And then afterwards at the kind of debrief, we got kind of talking, and Dan and I had already started some work on chemsex, because I'd been looking at it and noticing that we were seeing more patients who had been taking the drugs and then had developed kind of addiction and psychosis. So the team were telling us that they were going to these calls quite a lot. So Dan and I had started to put some training together for this, because it seemed 50-50, Dan, didn't it, across the service, whether people did or didn't know what chemsex was. And then we got kind of talking. I got talking to one of your APP colleagues on scene, actually, who said that he'd also been kind of doing some work, and then we were able to kind of join forces. And then I'll let Dan kind of come in to say kind of what we've been able to do here.
Yeah, absolutely. Yeah, and so yeah, off the back of these cases being flagged to us, and and it sort of becoming apparent it was like an increasing problem within the city, and by extension other urban areas will probably won't see it as much as in London, but it's certainly like a growing issue that's certainly at present not the needs of the community and people engaging and sort of going unmet currently. So our harm reduction initiative and a project was born through collaboration between the LAS mental health team, the advanced paramedic group, the LAS LGBT plus network also had involvement, and then we were supported by a group called the Gay Men's Health Collective, who've been wonderful partners and have helped sort of provide the limited sort of funding that was sort of needed to get the project off the ground. So to keep it really simple, we developed some sort of very discrete pocket cards that just contain a simple QR code, and the reverse side is just a very discrete design that doesn't, just very bland, for want of a better word, which our crews that carry them can offer to anyone that they meet on scene where they suspect that chemsex sort of may have been a factor. It can be offered to anybody, like I said, on scene where it may have been a factor, and then they must be over 16. They must have sort of capacity to accept the card, and they must sort of want to accept the card. So we're not forcing this onto anybody, and we're not sort of slipping it into people's pockets if they're unconscious, or it's it's a sort of more acute job, as the sort of sad case Carly just reflected on. The cards are carried by relevant specialist teams who are sort of seeing a higher proportion of these patients. So the mental health cars are carrying them, the advanced paramedics are carrying them, a few other specialist groups, and then sort of geographical hotspots, as well as staff members who are particularly interested, as they're probably the more people who are more likely to actually sort of remember to give them out in the moment. And then those QR codes that I mentioned on the card links to a bespoke web page that acts as like a single point of access to the content that's offering sort of help and advice on a broad spectrum of sort of issues and bits associated with chemsex, and that includes safer drug use, psychological support, access to drug and alcohol services, how to get help if you sort of experience a crime, that sort of thing. So the whole idea is that individuals navigate to the content that they want, depending on what they're looking for. And it's designed to be entirely, discreet, gender neutral, but be free of completely any sort of judgment or social comment. It's just about getting relevant harm reduction information to an individual, and at a time that they're receptive to it, or more likely to be receptive to it if they've witnessed something that's gone wrong, or which is something that we'd refer to as a reachable moment. And hopefully the advice there is sort of tailored to like these specific needs, or sort of what they're interested in accessing in the moment. So, for example, one person, may reach a point where they think that, things have gone too far and they want to access, psychological or drug and alcohol support. Whereas somebody else, to put it bluntly, may still be sort of enjoying the things that are going on and what they're engaging in, but having seen an incident where an ambulance has been required, might want to know how to look after somebody if something goes wrong. So yeah, I think it's a really good example, as Carly mentioned, of a case where the service was picking up on an issue that's covers both physical health and mental health. The overlap is there completely, and we've been able to take through a project that is now seeing sort of very positive outcomes with people who generally would be going under the radar and are more likely to not access healthcare or sexual health services, hopefully getting the information and support they need. And as Carly sort of alluded to, even smaller change, and this is something we're always really keen to push, even sort of smaller change projects that can be quick, relatively cheap. Anyone can, at any level in the organization, or in any organization you're sort of currently working for, can sort of push for it and really advocate for it and make it happen. And this project was quick, cheap, and pretty sort of easy to get off the ground, but it's probably been one of the most rewarding things I've certainly worked on in the last sort of year or two. Yeah, Carl, I don't know if you've got any more reflections on it.
Yeah, and I think it's just great that because we've kind of collaborated with kind of other professional groups within the organisation, and we're now just commencing a kind of prevalence study as well. So yeah, it's been great actually to do this, and yeah, just having that helicopter view across the organisation can help have drive change. So yeah, as you can hear, we're very passionate about it. Yeah.
So just as we finish off, could I just get you to both speak to really how you measure success within pre-hospital mental health crisis care, and indeed maybe some of the biggest gaps yet to close within the service? Carly, if I could come to yourself first.
Yeah, that's a really interesting question. Dan and I we've talked about this quite a lot, and I guess in a kind of very odd way, success could potentially be not needing so many of our kind of service actually, because if we worked in a more preventative way, then people may not need to call the ambulance as much as they have to at the moment. That said, that we don't want to go anywhere, and we have really good outcomes, and our kind of patient feedback is excellent. So I think I would like to see, there will always be people who do call an ambulance for their mental health needs. That's never completely going to stop, and nor should it. Everybody has a right to call an ambulance when they need one. But I think, yeah, something that we're keen to look at is the prevention work, and how we can support kind of partners. I also work quite closely with our frequent caller team as well, because obviously we do have a kind of group of patients who will use the ambulance quite frequently because of unmet needs. So yeah, it's about ensuring that we're kind of doing that liaison work with relevant services, could be mental health, social care, voluntary sector, drug and alcohol teams, to make sure that the need is kind of met in the community, which is, we know that if people are treated in their community, they get better quicker and the outcomes are better. And, whilst the ambulance service does great work, we don't kind of caseload people and build relationships with people like a kind of 9 to 5 community team could do. So that's something that we're keen to kind of support and just continue to kind of strengthen our relationships with our partners, really. I think that's a key focus at the moment.
Yeah, indeed. And Dan, to yourself.
Yeah, thank you. So I guess from maybe from like an operational perspective, I guess some measures of success for the pre-hospital setting I would be, I guess, from a more quantitative viewpoint, more referrals when safe, into community teams or back to the patient's own team. Obviously, as we've said before, sometimes the emergency department is the place the patient needs, but there's certainly there's definitely room for improvement there, and ensuring more staff feel empowered and have the education to be able to sort of make safe decisions to refer into the community, as we know that's often a better setting for the patient to sort of receive mental health support for a plethora of reasons. And then sort of additionally to that, I think for ambulance crews, as we sort of move our training and how we're trying to frame all our training to frontline colleagues, sort of away from sort of older mental health training that I think often defaulted to sort of quite theory heavy, getting bogged down in sort of minutiae detail of how to diagnose certain conditions. And actually, we're sort of trying to pivot to much more focus on crisis management and how do you sort of empathetically treat a person with respect and de-escalate a situation and find a safe care pathway. Just to see crews better able and equipped to communicate really well and in a respectful way to find the best outcome for their patients. And address, a significant area of health inequalities.
Listen, that's fantastic. That's fantastic just to really have a wide-ranging conversation with both of you about service delivery. We're going to do a deep dive into more pathology-based episodes shortly. But listen, thank you both for your time. It's fantastic just to get your insights.
Thank you. Thanks.
Thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.